Hi, everyone. I'm Dr. Travis Whitney. I'm the founder of Innate Healthcare Institute. And thank you so much for allowing me to present at your conference. Thank you to the whole tribal nations that has given me the honor to do this opportunity. And if you're watching this on our YouTube channel, this is a presentation prepared for a conference, for a regenerative medicine conference. But I figured it's so needed that we could put it on here as well, and hopefully you benefit from it. So let's jump into, this is the opening slide. We're going to talk about umbilical cord tissue, mesenchymal stem cells, mostly some exosomes in integrative care. And these are some clinical applications that we can do for type 2 diabetes. I only wanted to focus on type 2 diabetes for this presentation, although it is relevant for type 1. It is a bit different. So we wanted to focus on type 2 because that is more prevalent in the nation, in indigenous tribes that we're seeing here in the U.S. And so I thought it'd be more prudent to focus on that. So let's just do a little bit about me in case, for the people in the conference. And if you're watching this at home, and if you've never seen any of my, you're new to the channel and you haven't ever seen any of my videos or anything. So a little bit about my background and biography. I was born and raised in the Southeast, Northwest Florida, which if you don't understand Florida, the more north it is, the more south you are, the more southern you are. So I'm from Northwest Florida, and the more south you go in Florida, the more north culturally kind of you get. So very confusing, but very fascinating once you start thinking about it and looking at it. So I'm from the beach area. I'm a beach boy. My first degree was in psychology with a minor in philosophical and religious studies. I moved on. I used that degree, jumped into the Army for a little bit, got done with that, and was going to go into neuroscience, study neuroscience and a PhD program, and decided I wanted to do more medicine in general. And so I got accepted to a naturopathic medical doctorate program. And I did that concurrently with a master's program in integrative medical research. So I did those two together over 4 years. After I was done with that, I moved to Arizona. I did a master's degree in Chinese medicine as well. So I have a lot of school, a lot of education, and a very diverse background. Most of my the clinical experience when I first started had a big emphasis in diabetes, weight loss, and orthopedics. Strange mix, I know, but they do tie hand in hand a little bit. But I got turned on to injection therapy about my second year. I was shadowing a doctor, and he was really big into diabetes and weight management. And he also on the side did prolotherapy and injections for people with severe joint pain and stuff like that. So I learned them both. And then as I graduated, I tended to use the orthopedics a bit more. And that's just how I kind of had made a name for myself. And a company found me and said, we need somebody to inject stem cells. And I probably turned them down like 5 times before finally I decided to do it. So I did stem cells, biologics, actually, to be very specific, because they weren't actually practicing stem cell medicine. And that's a big distinction that we're going to make. And it's a big distinction you've probably heard on several of my talks and videos. So they were using commercially available biologics. And I was reading stem cell research, right? Like live expanded umbilical cord stem cells. So that's how I got into stem cell medicine. After I'd left that organization, I said, I think I want to do it better. I think essentially, I think I could do it better is really what it came down to. And so I switched my practice, which was kind of purely focusing on more of a direct primary care model for chronic diseases, to integrate stem cell medicine. And then I just became so successful with stem cell medicine that I stuck with it. So most of my organizational memberships and affiliations and trainings have revolved around stem cell medicine for the past 7-8 years. And it's pretty much primarily of what I've done. And because I do have such a strong background in more of the holistic and integrative care, combining like Eastern and conventional Western medicine and naturopathic medicine, that we tend to do a little bit of everything now at my practice. I currently have 4 doctors working for me. I do a little bit of patient care nowadays, but I'm more so a lot focusing on research. I'm running, kind of like a medical director, and as the owner of the clinic, and so and kind of just guiding the doctors as best I can. So this is my practice, Innate Healthcare Institute. We specialize in stem cells and integrative medicine. If I was to toot my own horn, we're probably the leading regenerative medicine in the United States. I still get patients every now and then. I just had one the other day. He had paid his executive assistant for 2 weeks to only focus on what's the best stem cell place to go in America. And Innate Healthcare Institute was the answer she gave him emphatically after 2 weeks of research. She said, this is the place you have to go. And they are doing really good. And so it would be really embarrassing if they weren't. But I thought that was a good, because I don't get to hear that stuff a lot, not being in the face-to-face with the patients a lot. So we specialize in umbilical cord, tissue-derived stem cells, exosomes, integrative care. We see a lot of children with autism. We see a lot of patients with chronic illnesses such as diabetes, a lot of orthopedics, and a lot of longevity and anti-aging medicine. So we do that with a regenerative touch, but also it's very personalized. I think one of the areas with regenerative medicine that's kind of gotten lost is this personalized touch, to where there's a lot of medical tourism. You fly out of the country, maybe you go down to a quick stop in Mexico, and there's this thought that if you just get stem cells in your body, you'll fly home and everything will be cured and fixed. And while stem cells is an amazing medicine, I wouldn't be doing it if it wasn't. It's usually a lot more deeper than that. So some disclosure. To be on the safe side, umbilical cord, stem cells, MSCs in general, exosomes, regenerative, pretty much almost all we do is not FDA approved. Use of these is considered experimental, off-label. As a founder of Innate Healthcare Institute, I have incentives to promote, because that's what we do. So sometimes people get a little upset about that. But hopefully with what I educate you with, you'll have enough to make a decision, whether you come to Innate Healthcare Institute or not. But you should be well aware that if you're talking about diabetes and umbilical or mesenchymal stem cells, that you know what it is you're getting. And I think that'll make a lot more sense later on in the presentation. So why does regenerative medicine in diabetes matter? Well, since this presentation is more so specifically made for the tribal nation, especially in North Dakota, along the Native American population, they seem to be very, very highly susceptible to type 2 diabetes. Some of them, populations, even the Pima tribe here in Arizona, recorded some of the highest incidence rates of type 2 diabetes in the entire US. So probably a lot of genetic influences going on there. They are a really great population to study. So not only is it very prevalent in a lot of native populations, but all over the US, as I'm sure you're well aware, with even an estimate of, where is that stat? Around 8.7 million estimated are unaware they even have the condition. Where do we start? I'm going to kind of go over this part a little fast, because it is a regenerative medicine conference or presentation for type 2 diabetes. But there's a little bit of background we have to go through. But I won't belabor all the diagnostic stuff and stuff like that. But it is important to know for preventative measures, right? Like an ounce of prevention is worth a pound of cure. So if you are getting blood work done, you're seeing your doctor, maybe they don't make a big deal of it. They're like, oh yeah, your blood sugar is a little high, these couple readings. you should probably click dial in and say, no, I want to do something about this now. If it's a conventional doctor and they're kind of like, you're just under that insurance model and they're like, well, no, we're not going to worry about it. Then go see a more private doctor in private practice that's going to say like, yeah, there is something we can start doing about this. So here are some treatment goals and some standards of care from the American Diabetes Association. Fasting glucose sugar between 100 and 125 is indicative of pre-diabetes. You should probably try to get like 3 readings of that. Don't freak out if you have 110 from one fasting blood sugar. There's a lot that goes into the dynamics of measuring that. Using a CGM, a continuing glucose monitor, has become really popular. You've probably seen them. It's a little about quarter-sized white dot on the back of people's arms. I just used one for a couple weeks. It's kind of nerdy to say fun, but it's cool. It's cool measuring your blood sugar in real time. You get real time data so that when you eat food, you can look at it within, over, a couple hours or so and see like, oh man, this stuff is really shooting up and spiking my blood sugar. And that way you and your doctor can look over it. So where to start with diabetes? Nutrition, of course. It's talked about a ton. It's beating a dead horse, but you've got to. Even with doing stem cell therapy, some of the dramatic changes you'll see with some of the patients we've done or some of the research, you'll see that you get from a regenerative approach. I still think it still aligns with the adage of like, you can't out exercise a bad diet. I feel like I'm saying it wrong, but you know what I mean? You can't outwork a bad diet. So no matter how much you're working out and exercising and stuff like that, it's got to be really extreme. But if you're still eating really bad, you're not going to make the progress. And I think with type 2 diabetes, it's still the same. You still really do have to come across and focus on your nutrition. So a couple of, let me see, I wonder if my cursor works on this. Emphasize a whole food diet, Mediterranean, traditional indigenous even is something for the tribes to look back on and look like, what were you eating for thousands or tens of thousands of years that all of a sudden this addition of this processed food, high sugary food and higher amounts of carbohydrates in general might be causing you to develop diabetes faster in the past couple generations than you had ever seen in your whole family history. Physical activity, we've become a much more sedentary society in general. Don't go crazy. Don't try to train for a marathon right out the gate. Start with simple changes like adding 7,000 steps a day. Build up to this moderate to vigorous aerobic exercise plus 2 times a week resistance training. That might even swap for you. You might even include more resistance training like with weights or resistance bands and start less with aerobic, and you might get a more bang for your buck doing that. Take a lot of breaks. Don't sit for really long periods of time. Weight loss targets. Of course, I'm sure if you're type 2 diabetic or you're overweight, again, like you've heard all this, but you need to sit down and understand, and that's where the behavioral support is going to come in, that it's not to be taken lightly. It is very serious. It is going to be make a huge difference in you, but you've got to dial it in. You can't this isn't a lot of fluff and talk. Track calories and protein intake mainly. Don't avoid long-term fad diets. Avoid just the general, like, I'm just going to stop eating carbs, but I'm not going to track my calories. Tracking calories is still the most researched and efficacious way to target weight loss. Plenty of misinformation out there on social media, plenty of 23-year-olds hyping up their fad ketogenic or whatever diet. But just take my word for it. As somebody that's been there, done that, almost 45 now. I did all that bro science back when I was in my 20s and 30s, and having kids and having kid working and stuff like that, I just got fatter. So I wasn't able to make a change until I tracked calories. Behavioral support, things like cognitive behavioral therapy, because it's not just purely biological. It's also our thought patterns and our behaviors that lead up to stressful binge eating or something like that. And so CBT is a great way to address the emotional and behavioral changes. Because diet, it's so personal. I've seen it for years in clinical practice too. It's like you talk to somebody about what's the best objective thing for them diet wise, and everybody almost always says the same thing. No, I eat fine. No, what I'm doing is good. I'm doing this because so and so. I saw some popular doctor say it, and that's what I need. Yeah, actually, we'll touch on a little more on getting hung up on our diet a little later as well. But Mediterranean is probably the largest body of high quality and long-term evidence for improving your hemoglobin, ABA1C, weight loss, cardiovascular risk. It's a good diet to stick with. You can still eat a lot of good, healthy foods for you, and it's very evidence-based. So it's easy to Google. It's easy to find cookbooks and books and stuff like that around it. And so incorporating that and at least starting there is a great way to start. Low carb and very low carb diets with less than 130 grams a day of carbohydrates. Again, this is why it's so important to track. At least track, and don't get overwhelmed about tracking, and don't get too stressed out about it. Do it until it starts to kind of become a second nature to you. And it's stressful. I didn't like doing it. I don't like doing it. There's still days where I don't even do it, because now I've kind of got the sense of like what I eat, portion size and weighing and stuff like that. I kind of got it down. It starts to become a little bit of a second nature to you. So take a break from it sometimes if it's overwhelming and you've got kids and work and stuff's going crazy, then just don't do it for a day or two. But try to get it dialed in for at least like a month or something of sticking with it. So it becomes more of a habit and it changes your behavioral patterns. Let's see. So here's some information about studies and research that show where very low carb diet and low carbs kind of come into play. They help with the body weight and increasing the beta cell function. So I think it's something to use, especially the very low carb diet. Some people are going to respond genetically better than that. I can't really speak because I don't see any data from indigenous tribes, but this would probably be one where you would probably respond better than maybe like a European. Somebody with like a European background. So let's see. So let's dive into why you're really probably here, the regenerative medicine and diabetes, and let's talk about the mechanism of actions and how they work. So while this slides up, I also want to go over my normal kind of a spiel on what I tell patients. So I kind of see stem cells, but mesenchymal stem cells, as doctors. They go in the body and they listen, right? The root word for doctor comes from docere, which is a teacher. And so a doctor is kind of supposed to listen and teach the body. So these cells do a really good job of listening to the environment. And that's done by your body signaling things through like what's called chemokines and cytokines and chemical messengers that are in your body and that your cells are sending across, talking to other cells in the body, right? Because that's all we are. That's all we are, is a collection of these cells, and all these cells are talking to each other. So it's about communication, and that's what these cells are doing. They're communicating. So they're doctors that are picking up on the environment, and they're listening to all their patients, the billions of cells and the trillions of cells in the body, and they are making medicine. They listen to their body, and this is why I'm a huge proponent or fan of live stem cells as opposed to just exosomes, because the exosomes and other signaling packages and growth factors that they make are the medicine. In my analogy, that's the medicine that the stem cells are sending out. So for me, I'd rather have the doctor make it to order instead of the exosomes just blindly going in. And It's not knocking exosomes. Exosomes are amazing. We still get really great, you can still get really great results. But I think if I was to have a one tier up, like an S tier, and then it would be stem cells and exosomes, and then exosomes only would be the next best thing. So they're great at immunomodulation. They're going to talk to the immune system and make it more of an anti-inflammatory instead of a pro-inflammatory. And you'll hear this a lot, especially over the last 10 years. Inflammation has become a big buzzword in medicine in general. Everything's inflammation. Everything is too much inflammation. It's about finding this balance, right? So they're great at modulating the immune system, not suppressing. I've heard that a lot. It is something that as clinicians we should be aware of modulating the immune system, but suppressing the immune system is not exactly what they do. So for tissue repairs, one of their mechanisms of actions, one of the things we're looking at is supporting the beta cells, those cells in the pancreas that are in charge of producing insulin and everything, and the whole, really a big key cell that functions in our glucose regulation, in preserving that, preserving the via the paracrine signaling. And what that paracrine signaling mean is that crosstalk communication. So paracrine signaling is when a cell secretes something and it's traveling, through the bloodstream or in the environment that the cells are in, to another cell. So you'll see that come up. It's a big deal. Paracrine signaling is one of the ways that we think stem cells are doing what it is they do. Angiogenesis support, so promoting vascular repair, which is really big in repairing and preventing neuropathy and nephropathy. So if you have, it is another condition we treat, more so than neuropathy for diabetics. Even if somebody is not even labeled type 2 diabetic and they come in for neuropathy, we're always talking and working on their blood sugar. Mitochondrial rescue, this is one of the newer areas of research. So enhancing energy metabolism and glucose uptake in the muscle and liver, sending out. So apparently what these cells are able to do is the mitochondria in our cells are basically little energy houses. They're little engines and productions of energy. And if one's faulty and bad in a cell that's not doing healthy, these stem cells are supposed to provide a new mitochondria, or maybe it's repair, but the thought is that they provide new mitochondria to cells. Immunoprivilege. So if you're looking into stem cells, if you've heard a lot of talk, there's different kinds that we'll talk to over the next couple of slides. But these cells, and you might think because they come from somebody else, we're talking about an umbilical cord. We're not talking about your umbilical cord. We're not talking about your sons or daughters or anybody else. It's from a donated cord. And because of the low immunogenicity, you don't need what's called HLA matching. You don't need to do special tests for these cells from an umbilical cord to work on you. I could take a batch of stem cells from an umbilical cord, culture and expand them. I could give them to a diabetes patient, and from that same batch, I could inject them into my knee. I could give them to somebody for a child for autism. So these are very utilitarian approach, a very universal approach for medicine. So let's go into some of the clinical outcomes in the research. So measuring A1C, you can see with the registry study that had about 218 participants, and the A1C lowered 1.2% over a period of 6 to 12 months. That's pretty good. Diet alone, has been shown to at least do 0.5%. So that could be a make or break diagnosis. If you're at 5.8, 5.9%, your glucose is starting to get out of control, and you just do diet alone, like you could be considered non-diabetic within like 3 months or something. But to have a 1.2% change is huge. So that's even leaving somebody that's, up to around 6.5 on their A1C, and being able to lower it that much, which we'll see and we'll look at a little bit later. So we see in improvements in insulin sensitivity, inflammation and CRP and IL-6 levels, Medication use is very common too. So patients start wearing off their their metformin and other medications, and really no serious treatment-related adverse events in studies. I'll try to go over. I'll do like some research first, and then I'll get into more of what we see and do in my clinic. So what we're talking about with our stem cells, and actually a slide before I even touch on that, something sparked me to talk about legality. You'll hear a lot that stem cells are illegal in the U.S. It's still prevalent. Anything from a confusion to straight out lies that a lot of people are propagating, especially overseas clinics. I feel like they want Americans to think, I can't get this here. Shucks, I have to go overseas. I have to go to Mexico. It's not true. I didn't have my slides on here. I didn't add those slides, but I have slides where I've hired healthcare and FDA attorneys. So I won't belabor that because I don't have slides for you to look at, but it's not illegal in the US. It is more state varies by state and state. So I'd be interested to know how a tribal nation land and what that would look like for you. So I'm happy to go over that with the leaders and see what that looks like. But in general, no, there's no law. There never has been a law that outlaws stem cell research or experimental use in the U.S. That's not my interpretation of the law. That comes from attorneys talking to the lawyers. So, okay, that tangent's done. So when we are comparing, let's talk apples to apples. Umbilical cord MSCs, or stem cells is an umbrella term. We're talking about umbilical cord stem cells that come from the tissue of the umbilical cord, not the blood, but the actual tissue that makes up the cord. There are bone marrow and there are adipose fat-derived MSCs. Here are some comparisons of them. So one of the things I love most about umbilical cord is it's non-invasive. It's coming from a donated cord. That cord's going to get thrown away anyway. It's going to be considered trash and get tossed out. Whereas bone marrow and adipose are surgical procedures, or some call them minor surgical or very minimally invasive procedures. But it's still a procedure that has to get done to you. So in the proliferation capacity, so that's the capacity to grow the cells to higher numbers, which is very, very, very important from a clinical point of view. Very high for umbilical cord. Bone marrow and adipose are okay for expanding. The senescence risk low, higher with adipose and bone marrow. Also, that means less cells are going to die. Again, when you're using them on yourself, very low for any reactions for umbilical cord. Moderate to low. I would have rather added low in there, but moderate for bone marrow and adipose if you're having it done to yourself. That paracrine potency, that paracrine secretion that we talk about, very strong. Umbilical cord are very strong in growth factors. Bone marrow and adipose, it depends on the health of the person. So as you age in population and age and increase in disease, these cells become less viable, they become less healthy, they become lower in numbers as we age. So, a 60-year-old, 50-year-old or 60-year-old with type 2 diabetes and other heart conditions, pulling those cells probably isn't the best option. This isn't just this isn't my bias towards umbilical cord stem cells. Say, well, because I use umbilical cord stem cells, I'm going to say that these other cells aren't as healthy. This is published research, and it's why I chose umbilical cord instead of bone marrow or adipose, which is a much easier road I could have taken. I took a much, much harder road to focus on umbilical cords. Sorry, my mic's in the way, so it's weird. If I move my head, it's because I'm trying to look around it. So the clinical use, really great because you can create like an off-the-shelf product. You can have billions and billions and billions of cryo-frozen umbilical cord cells. Where I don't work with bone marrow adipose, but most of the time, you're doing it right there. You're harvesting from the tissue, and then you're using it right there on site. I don't know. There's not a lot of expansion in those. I know there was a case with a doctor in California that expanding adipose, where the FDA tried to come in and tell him he couldn't do it, and they lost that case. So it was very, very promising and very, very good for the field in general. But like I don't work with those, so I can't speak to them too much. Just a different picture, kind of saying the same thing. Again, if you focus on that paracrine secretion down at the bottom, the highest levels of those growth factors and proteins and exosomes and everything, the stuff that's going into the other cells and repairing them, is very high in umbilical cord tissue. So more pros and cons. MSCs, umbilical cords, MSCs are very easy to come by. You're just taking a cord that's going to get thrown away anyway, versus the BMAC or adipose tissue, which aren't as healthy, could not be as healthy of a cell, and it's harder to get them in the first place. Okay, so are all stem cells created equal? So stem cells, I said, is an umbrella term. And then you have all these other terminologies over the years that have developed. And one of them is biological products. So companies make biological products. They'll call them Wharton's jelly. They'll call them stem cells. Either they call them stem cells or the clinics will call them stem cells, but they don't actually have any stem cells in them. So I don't think this is as relevant to the tribal nations. It's probably more relevant to somebody else watching it elsewhere. In the tribal nation, if like we discussed, if you are planning on only starting like stem cells and using them for your population there, this probably won't matter as much to you. But if you're getting stem cells, anywhere else, mostly around the US, you need to know what you're getting. You need to understand live cell counts versus a TNC, a total nucleated cell. So just a quick recap on it. Live cell counts is a dosage we use in stem cell medicine. So 100 million cells, 50 million cells, 10 million MSCs. It's specific to the MSCs, whereas a total nucleated count is something a biological product might say. And a lot of times these clinics that use these will promote them in volumes. So like you're getting 6 units of stem cells, or you're getting 5 cc's of stem cells. And that volume doesn't tell you what's in stem cells, because I can put 10 million stem cells into 5 milliliters, or I can put 100 million into 5. So what they'll do, they will give a cell count, and it's any total nucleated cell. So it could be a fibroblast, it could be an epithelial cell, it could be a white blood cell. And they'll say, well, with this bottle or vial, you're getting 20 million cells. And so the proper thing to say is 20 million mesenchymal stem cells, or 20 million just any kind of cells. And if it's mesenchymal stem cells, do you have it characterized? Do you have the flow cytometry report or some sort of test to show me that it has the CD markers, the positive CD markers and the negative CD markers? So there's a lot to go off of. It's almost a whole nother presentation in and of itself. So here's comparing some. These are commercially available biologics. Sometimes they're called Wharton's jelly, amniotic fluid. Sometimes some people call them PRP. They'll use PRP and they'll call them stem cells. So the live stem cells are expanded, viable, live stem cells. There's usually no cells at all or very little in the biological products. So these mechanisms of actions for the live stem cells are cell-to-cell contact. They can home and travel to different parts of the body that need it, or that are giving off these high inflammatory signals. They have the paracrine signaling. There's some differentiation that's been hard to measure, but so for instance, if I put them, or actually let's stick with diabetes. If we put them in, especially close to the pancreas, they can differentiate ideally in 2 cells that are more effective for diabetes or for neuropathy, going in as a stem cell and converting it into like a nerve cell to improve that condition. So live stem cells are longer acting. They can proliferate, sustain local effects. Commercial biologics are very short acting, and they're very good, by the way. I don't want to crap totally on commercial biologics. They're a lot better than some other options. But if we're talking about calling them like a stem cell or comparing them to stem cell therapy, it's not the same. So more stronger immunomodulation, more clinical research done. There we talked about the marketing claims and stuff. So let's dive into a little bit of research. I don't want my camera to die on me either. And I am prone to talking because this is all I do. I can talk for hours and hours. I just recently did an autism presentation on autism and stem cells and integrative medicine. It was easily an hour and 30 minutes. And I was really trying fast to go through it. So this is systematic review and meta-analysis. So if you don't know what those are when researchers take all the studies that they can find, and then they pick the good ones. They put out the ones that weren't really good research done. And then they look at all these good research and give you an overall view of it. So this one was great. Let's just jump straight down to the conclusion. Umbilical cord mesenchymal stem cells therapy reduced A1C and insulin requirements. They increased C-peptide levels, which is another lab marker we look at to see how well the pancreas is functioning. This one goes on to say it's, you need more research is what every research ends with anyway. Let's look over. So let's see. Face favorably in type 1 diabetics, the insulin requires decreased considerably. Very good p-values. So very good. Some interesting research there. This is another study. Efficacy of umbilical cord mesenchymal stem cells in the treatment of type 2 diabetes is assessed by retrospective continuous glucose monitoring. So that's what I was telling you about, that little thing that you use. It comes in a little plastic container and you pop it on your upper tricep, and there's a little filament, a little wire, and it just pokes into your skin and just into the surface level. And you download the app, and then you look at you can see real-time data on what your blood glucose is doing. So it was really cool that they measured this, and they used that. And so here's the abstract. Here's some of the research, or some of the results that they saw. If you look at about halfway down, let me see if I can use my cursor. Compared with the placebo group, umbilical cord mesenchymal stem cells group exhibited more pronounced changes at 9 and 48 weeks from the baseline TIR, which is time in range, and their A1C. These results illustrate that umbilical cord mesenchymal stem cells administration via intravenous infusion is an effective approach. So that time in range is what they were looking at the most. So time in range is where like your blood glucose is in what we consider like a healthy range. And what will happen for diabetics, because their body is not as good as controlling that glucose, is it stays high. And again, it's about balance. Like there's problems that come with it being excessively high. And then when it all get used up, it might shoot too excessively low, which is why diabetics need to keep some sort of glucose or snack on them. And so both ranges are bad. For the long term, the continuously high glucose causes problems. And then in the short term, having, of course, a hypoglycemic event can be very bad as well when your blood sugar goes really low too fast. Is this the Zhang et al.? Yes. Yeah. So yeah, I love this. This is like probably my new favorite study. It's the first I've seen that uses a triple infusion approach, which is what I've done over the years. I'll puff up my chest here and brag. But that's what I have done over the years. I implemented that. So I don't know, actually, I don't know them. So I don't know if they know that we were doing this or had heard about it somehow. I haven't coordinated with them, or maybe they just did it coincidentally on their own. And it was just happen chance that they did it like this and got the best results that I've seen out of stem cells and diabetes research. So it was double-blinded, placebo-controlled. They focused solely on type 2 diabetics, and they did the continuous glucose monitoring. And it really just puts it at the top of the hierarchy for evidence, in my opinion. with my little cursor. So they used P4 cells, which is an early passage, but it's not what's conventionally used. So for when you hear things like, and this affects more of the tribal nation, if you plan on doing everything yourself, so to speak, and controlling your own stem cells, like we do at Innate Healthcare Institute. The fourth passage is how much you divide a cell. So that cell, and I think I have a slide that talks about it a little later, but you grow a cell and then they get too crowded, and then you take them out and you put them in a new container and you start growing them again. And we call that a passage. So the more you divide a cell, to within reason, the more you divide, the unhealthier it gets. But it doesn't happen immediately. And I'm pretty sure I went on a huge tangent with this. If not, I'll cover it later. But so they did passage 4. Usually, clinically, anywhere from P0 to P3 is used the most. So it was very, very cool that they used passage 4, because I think that's very promising for clinics. Because the more time you can pass and grow a cell, the higher the dosage you can get, the higher number of cells, which means you can treat more people. You can do more treatments, which, as we'll see, also makes a huge difference. So they did about 70 million cells per infusion, 3 times, 4 weeks apart, for roughly a course of 210 million cells. I tend to start people with chronic disease at 300 million. They measured 48 weeks out. So everything was, most of the things were statistically significant. And a better change than a lot of the other research. Some of the research, while it did say it had improvements, they were very minimal. And so I don't love that about some of the research on stem cells and diabetes, where they say, we saw a great change in the A1C, and the A1C changed by 0.2 points. It went from 7.5 to 7.3. And it's like, yes, okay, you're in the right direction. I get it. Like, yes, it's a change, but we want to, ideally we could see something better. So in this one, 43% of the stem cell group versus 11% of the placebo group achieved an A1C less than 7%, and 70% of the time their glucose was in the better time and range. So this is a great study. This is a great study to look at and mimic for the doctors and clinicians out there that might be watching this. This is another one I came across, and I think this one I'm going to talk about. No, I didn't. I think this is one of the ones where it's good research. The effectiveness and safety of human umbilical stem cells for treating type 2 diabetes. Results of this study suggest that infusion can improve glycemia and restore islet beta cell function. I didn't love this study as much. I'm skimming through to see what I didn't love about it as much, but as much as the other one. Dosage of hypoglycemic agents was reduced in all patients, of whom 6. It was they had a low participant count. 50% had a decrement of more than 50%, and 1 discontinued their hypoglycemic agents altogether. So a pretty decent study showing it more. This is a retrospective study. So in this one, the conclusion down there, allogenic umbilical cord MSCs infusion is safe, good outcomes. They sustain benefits up to 12 months. The treatment significantly improved metabolic indices, including glycemic control, liver and renal profile, systemic inflammation. So there's lots of good data out there, and it's all very elementary, or like, what's the right word? It's all kind of very new and very simple. So like for this one, I think they did 1 IV of 50 to 100 million cells. That's right. So they did 50 to 100 million stem cells. And so it's not great. Like who got 50 and who got 100? Why didn't everybody get 100 million? And they didn't really, I don't think they really tracked the 50 million compared to the 100 million. I did elaborate on this one. So this one, they didn't have a control arm. There's confounding factors, like did stuff improve over the time period from diet or prescriptions or other interventions? They didn't measure. In this one, they did use a higher seeding. They thawed and expanded up to P6, which is a little high of a passage. It's not bad necessarily. It's just you're going to lose a lot of efficacy once you get to growing the cells to P6. It mainly involved infusion of 1 or 2 doses, like I talked about, with most of the patients just seeing 1 dose. And this is the one I was referring to. So the improvements are small. So they said it was a very good, significant, and it's still good. I'm not saying it's bad, but you go from 7.7 to 7.5%. It's like, all right, well, this is a start, but I think we're looking for a little bit something more dramatic. Okay, so let's get into some more sciencey stuff of stem cells. You could pause this since this is a recording. You can pause this. I really went on a big tangent on this because I just felt like it was so important to know, especially for you tribal nations and especially for consumers out there. Maybe you're watching this on YouTube or somewhere else and you don't know anything about this. And so you might just be taken to a clinic that you're talking to, maybe overseas even, maybe a very, very popular clinic that is charging a lot of money, and you're just taking their word that they're going to give you live stem cells. So many clinics and docs tout that P0 is a vastly superior and stem cell, and therefore they charge a very high premium. And so what they mean is that I've seen this on YouTube. I've seen doctors talk this, so I know it's going to get more and more popular. And I've already seen people in social media and forums and stuff like that try to swear that they've done the research and that they know what they're talking about, despite not even being in research or science or medicine at all. So it's prevalent. It's out there. I already know it. So P0s, you're taking the cells. They'll call them native usually, and it's just not growing or culturing them. And the take that they'll give is they'll make it sound like they're very natural. Like these are the native cells. They haven't been grown or expanded, and that's when they're the healthiest. And it sounds great. It sounds nice. It sounds like it could be true. And while it is, these are certainly amazing cells. There's no, they just say this without any clinical or published data. And that's my analogy of the world's best cup of coffee. So you've seen that tons of places. I think it was it was from the movie Elf. Remember, he walks in, he goes, "Congratulations, world best cup of coffee. You did it." You see that around. Like, we have the best coffee in the world. We have the best blah, blah, blah in the world. And it just reminds me of the places that say this. So here's what the difference is between passages. We talk about confluency, and that's when the cells are growing and they get kind of too crowded. And they can start to, it can lead to downstream bad changes for the cells. And we don't want that. So you detach them and you put them in another plate, or if you're using a bioreactor like we do, there's just different steps. So most clinics, they have a cell bank where we use P0. We have these cells and then we expand them. We keep growing them to higher numbers and to passage 1, passage 2, passage 3. So research-wise, I put a couple very good papers down there at the bottom for the clinicians or the scientists out there. P0 through P3 is considered a safe zone. The data shows that switching from P2 to P3, it's almost like a second generation of a photocopy. It's almost like you're looking at the same thing. You cannot tell the difference. And we'll look into that a little in the next couple slides. Clinically, if something's using from P4 to P6, and I like to give a general broad education because maybe a lot of times people can't come to Innate Healthcare Institute. Maybe they can't travel. Maybe because of kids, work, life, stuff like that. Maybe you can't come to this, but something's more feasible for you to go to. This is still really good information for you to know. So P4 to P6 is estimated about 15 to 30% of the therapeutic horsepower is being left on the table. So you're losing, you're losing a bit of efficacy, but still, I think it could still be used. And that's why I said it was so interesting that study used P4 and got really good results. Past P7, I had this analogy that they're like tired firefighters. If you ran flow cytometry on them, they say they'd have the same characteristics. They'd still be mesenchymal stem cells, but man, they're worn out. They're tired. They're not performing as well as they would have before. So we look at what's called a gene expression shift, a transcriptome drift, and that's measuring. That's where the scientists measure the genes, and they see how much these genes expression change between the generations or the passages of the stem cells. So here you can see at P3, you're looking at a 0.2% change. It's really no difference. There's no difference in doubling time, colony forming units, immunosuppression, migration of the cells migrating. So for all the clinics and places out there that are touting P0 and you won't make any change, and for the nations, if you get into this and it's more cost effective to have P3 cells than it is P0, which is odd because the places that say like our cells are P0 and they're native, if you don't have the money cost growing into growing the stem cells, the scientist time, the equipment, the growth factors, the media, all the expensive stuff that goes into culturing cells, why do they cost so much? And if you're doing consultations, ask those people that, like, why, if you're charging $30,000 for 50 million stem cells, and there's no research that shows that they're better than a P3, why are you charging so much for them? Sorry to stir the pot. Sorry if you own a clinic or something that does do that. But I think transparency is really important and is key. This is just more stuff on pause this if you want to look at it or take a picture, and you could look at it later. It's just more on comparison 50 million cells at P0 versus 300 million cells at, say, like P2 or P3, and some of the pros and cons. You could see over there on the right. So which one wins? I think 300. The higher the cell dose, within reason to the earlier passages, is going to win. You need more cells, and you need them more frequently than you do one treatment with a P0. Again, I'll probably make a whole video just dedicated to this. So subscribe to our YouTube channel so you can see when that comes out. And let's get back to the diabetes. Oh, there's so much good stuff. So much good stuff. I'm running out of time and battery. Here's some citations. Okay, let's look at the case review. So 72-year-old patient with dementia. Original presentation was coming in for dementia, but he wanted to also, kind of look at his blood sugar, but his biggest concern was his dementia. We started looking into his blood sugar and type 2 diabetes, and I said, I think this is where we should focus more, and they'll benefit each other. Focusing on the stem cells will benefit, or on the dementia, and the type 2 diabetes is going to help the dementia. So we started with some IV nutrients, tried to do some diet changes, an IV infusion of 100 million cells at P2 for over 3 days. And the next day he did a heel to toe walk that was nearly perfect. So let me show you. A heel to toe walk is when you put the heels of your toe to your toes. I know you can't see my feet, but you try to walk in a straight line. So he couldn't do that. And so one of the fastest improvements he made was that next day doing it, and it was perfect. So if you watch the video, which I was going to play for you, but it's about 6 minutes, and I think it's going to be too long to play now. But find this on YouTube. You can search right there. You can go to our channel and find it. Stem cell therapy for dementia and type 2 diabetes. There's the thumbnail, I think. Watch that. It's about 7 minutes long. Great story. Great story. Great patients. And they saw us for quite a long time. So let's look at some of his numbers. So here, if you look on the far right, on the left slide. So go to the left slide, and it's 2019 was when he started recording. So he's looking like he's averaging his glucose around 160, 150 probably. And then as it goes over in time to more of early 2021, you can see he's starting to average more around the 120s. Here's a longer one. So this is before he started in 2019. So it's before his stem cells. And now you can see a longer picture of after continuing stem cell and exosome infusions, where come back here and this time it's on the left of the slide. You look down here at the time frame. So the left of the slide is what starts earlier back in 2019. And you can see that as the averages dip, the top one is the highest peak for that day. And this is the low. So 110 is right here. And so as you go more into 2023, you can see where his average is generally lower. And he got really good, really low over here in early 2021. And then it kind of went back up. And this was not a compliant patient. He will admit his diet is not the best, well controlled. But you could see in 2023 that he's pretty much within normal levels a lot of the time. Here's some before and after infusions. So you can see on the left here, his average glucose, anything mostly around the 50s, 150s, and an all-time high, all-time max. This is back in 6/20/20. And then here in 10 of 2023, it's spaced out, so I couldn't capture a lot of them, but you could see, here's a glucose reading 96. His average is 130 versus 154. So a lot of good changes. This was another patient, 80-year-old male. You could see we were working on quite a bit, but September 2023, we start doing infusions with 150 million cells. We started adding some exosomes. We were doing some IV nutrients. And you could see on the left is before. So you could see his fasting glucose 118, a little bit on the high side. His hemoglobin's 5.8, not really bad. This guy had been a vegetarian, low carb, so he'd been working on the diet. So this is really good to emphasize the importance and how stem cells can make such a huge diet or such a huge change. You have somebody that's been working on the diet. They've been low carb. They've been doing things for years and years, and it's got them good. You'd even say maybe controlled. And then here we come down to after the stem cell infusions. Here we have a glucose of 80. So now he's well within the normal range. I am very upset that they didn't do an A1C on this lab, but I would bet that it's probably below 5.7 now. This is another one, a patient. The previous labs are over here on the right. And then these are the newer ones. So this is a newer patient. Haven't had a lot to work on with them yet. But it's trending. It's going in the right direction. 7.3 A1C down to 6.7. Big. 216 down to 168. Huge. Again, huge numbers that you can find with stem cells that you're probably not going to get even with medication and diet combined. So it's insulin. Let's look down at the bottom, which was 6.1, which is still, it's still a well in control range, but you can see that even coming down as well. So I'm going to try to start wrapping up. Just wanted to, first, if it blanks, thank you so much. And I wanted to give you another reference. This is by a friend of mine, Dr. Richard Jacoby. He sees patients at Innate Healthcare as well as his own practice. I'm super excited that he's joined us at Innate Healthcare because he brings a wealth of information. He has a couple books out. His newest one is called Unglued: The Secret Science of Stem Cells That Dissolve the Effects of Sugar. If you have neuropathy, you have to call us and talk to come see Dr. Jacoby. If you have nowhere else to go and you're at your wit's end. Diabetes, same. But he's a wonderful researcher, wonderful book. Quick, easy read too. It's not, here, I got it right here. 200 pages, maybe. Great book. It is new out. I'm upset that I haven't finished it yet. So I'm excited to read that. Here's some references for you. I probably missed quite a few, but a lot of the big ones are in there. So in these last few minutes, thank you so much for allowing me the honor of talking to you. I think this is a recorded present for the live conference. And so if you have any questions or anything, you can ask the admin, and they can, maybe we'll have a Q&A answer later. But such an honor for me to be allowed to and join part of your presentation and to be able to help everyone there within the tribe and everybody watching this online. If you're watching this on YouTube and everything, hit subscribe if you like stuff like this. We have a wide mix of things related to regenerative medicine and health in general. And not all of it's big, giant presentations like this. I have some other videos where I keep it short and sweet. So if this is right up your alley, please subscribe, give this video a like, and hopefully you can join us in the next one. Thank you so much.